Hi, welcome to our podcast today. We are very excited to have Dr. Jason Leonard here with me. My name is Amy Stevens. I'm the General Manager for Provider here at Innovaccer. Dr. Leonard is going to talk to you about his role as the Chief Medical Officer at Invio for Prisma Health. But let's go ahead and get started and hear from you how you got into this role, sort of what you were doing beforehand, and most importantly, what is Invio?
Great question. So, Invio is a value-based care network in central South Carolina and eastern Tennessee. We service almost 600,000 lives. And in my role as the Chief Medical Officer, I get to manage that value-based care network. So I really feel that my position lives at the intersection of data, provider engagement, and then clinical care systems.
That makes a lot of sense. And I love the fact that you said you get to do this. Right. So I'm hearing that this is something you love to do. What has brought you into this corner of healthcare? Or maybe it's not a corner, it's an intersection, as you said.
That's right. So in my prior role to this, I took over running value-based care for a different organization across several states in the Southeast. Mm-hmm. I went from taking care of 3,000 patients to tens of thousands of patients. Oh, yeah. And what I noticed across different practices were that the problems were the same. No matter what state, no matter what practice arrangement, the problems were the same.
Now, do your colleagues think that too?
They do.
Oh,
they do.
Interesting.
They do.
Okay.
I think this is quite a widespread thing, trying to incorporate these measures into actionable data in the exam room. Mm-hmm. And so I noticed that as I was crossing over state lines and different practices, the problems were the same. And then with Invio, I get to manage 600,000 lives. And so instead of impacting 3,000 patients, I get to impact over 500,000 patients potentially. And that really helped me make that transition, and it's something I'm very excited about with our network.
Absolutely. And talk to me how this network fits in with the health system larger. And you also have a health plan, Promise, right?
That's correct, yes.
And I bet that there's some of our viewers here who have a similar type of setup with a health system, employed physician groups, a network, possibly a provider-owned plan, a CIN. So those are a lot of different acronyms.
They are.
Tell us what each of them does, but most importantly, sort of how you help knit that all together.
Great question. So Invio is a clinical integrated network, as you mentioned, or a CIN. And we contract with independent provider groups in South Carolina and then also in Tennessee. But we also are part of a larger health system called Prisma Health. It's the largest not-for-profit health system in South Carolina.
Oh, okay.
And so we work with employed physicians from the Prisma system, independent physicians, and then recently we have our own health plan called the Promise Health Plan, which is essentially our own Prisma-based health plan, kind of a self-insured plan that we use to deliver care. And it's an incredible plan. It's a great benefit for all of our wonderful Prisma employees and their families.
And do you see that actually as a growth mechanism going forward?
Yeah, for sure, for a number of reasons. Number one, we get to kind of control the cost. That helps a lot. And being a hospital system, that helps. Number two, we can really kind of dictate care and make sure that our patients get excellent care. We can use the metrics that we have to drive patients to the most excellent providers. Mm-hmm.
And my understanding is Prisma has been building metrics that are what we might call payer-agnostic, right?
That's right.
Most people are very familiar with metrics that are specific to populations, specific to a payer, specific to the enterprise or health system. Tell us a little bit about those types of metrics.
So measures are not the outcome. Measures are how we get to the outcome. And as a provider, up until just a few months ago, I was seeing almost 40 patients a day. And when I would go in an exam room, I could not switch and say, oh, here you are, you're a Medicare Advantage patient. And the next patient, you're commercial. The next patient, you're Medicaid. There's enough complexity within the patient visit to consider who the insurer is, who the payer is. And so the goal is to drive processes and systems that raise the tide, that helps rise the tide for all ships. A rising tide raises all ships. And so the goal is that we can really help improve the care across the spectrum with processes that the providers do not have to think about what the payer is, who the health system is. They simply need to take care of the patient, which is what they're trained to do.
And what you're grounded in wanting to do, right?
Absolutely.
You don't want to look at somebody as a dollar sign on their forehead and try and figure out who their payer is, or lack of payer for
You're
that
exactly
matter.
right. You're exactly right. Because at the end of the day, when you're seeing patients, when you're in that exam room, you're not thinking about HEDIS metrics and CAPS surveys and anything like that. You're truly thinking about how you can take care of that patient that's right in front of you. And so our job is to work in the background to help processes, to help the medical assistants, the front desk staff, and of course the providers do that seamlessly.
Yeah. Now, many of our viewers are clinicians or are working with clinicians. We've seen a general increase in the physician executive role and dyad type of leadership
right.
partnerships. Talk to me a little bit about how you've seen that developing and even how you see being one of those who can show us what a good version of that looks like.
You know, at Invio and at Prisma, we really believe in the dyad model. And it really is nice to have someone with a clinical background who is active with patient care, but then someone also with a little bit more of the administrative background. It really helps to have a partner that looks at things from a different lens. You don't want a partner that has the same background as you do. You want to have the different lens. So we really believe in the dyad model at Invio and at Prisma.
Do you have an example of where maybe a little bit of that tension between the two of you may have ended up with a better result or something you wouldn't have thought of?
Absolutely. You know, so for me, I'm very patient focused. Again, my 20 years in healthcare have been essentially seeing patients boots on the ground. This chief medical officer role with Invio Health Network is relatively new. But there have been many times I'll have someone, my dyad partner will not have any clinical experience, and she'll come in and say, we should do something this certain way. And I'm going to say, hold on a minute, like that makes sense conceptually, but it doesn't translate well into the actual exam room, which is where it really matters.
Right.
And there are other times where I feel like something makes sense from the exam room, and she said, hold on a minute, we have to go through this policy or this process or this financial outcome. And so it's great to have that check and balance system, give and take. That's exactly
for
right.
sure. So that actually kind of brings me to a question about in the clinically integrated network and having run one myself, I know that's the goal, right, is integrated, but
That's
many
correct.
times it's still pretty fragmented. How have you thought about where you wanted to get standardization within your network and where you've said, you know what, that really is best left to that provider to have some level of differentiation in what they're doing?
That's right. You know, healthcare we often say is local, but I disagree to a standpoint. The way you take care of diabetes in Seattle is going to be no different than how you take care of diabetes in South Carolina.
I bet there's some viewers that agree with you on this.
And they do. They probably, hopefully they do. You know, the ADA guidelines are the ADA guidelines. And you might have a sicker, healthier patient population. But overall, the way you take care of patients is similar. Now, practice dynamics, sometimes, for example, if we work with one of our independent groups, they have way less support resources than one of our employed Prisma providers would have. So that's a very, very different approach. But at the end of the day, you want the same outcomes. You know, if I go to a Starbucks in London, England, or I go to a Starbucks in Mexico City, Mexico, I expect my coffee to taste the same. I expect consistency, and that's what we are trying to deliver with this organization, is in the background, put in the people, in the processes, and the systems that can lead to better care regardless of the outcome, regardless of the circumstances of your practice environment.
That makes a lot of sense. You talked a little bit about oftentimes those network providers don't have the wherewithal in order to do some of these things. So how do you see the CIN balancing this ability to take care of patients differently and yet the reality of resource constraints inside of the practices?
You know, especially with these independent network providers, you said it perfectly. There are lots of constraints that hospital-employed providers do not have. And so my role as coming from someone who for 18 years worked at an independent group is to translate my successes into protocols and processes that can improve their performance. So we will literally, our team at Invio will go and we'll meet with independent providers and we'll have what we call boots on the ground, where we sit there and we will watch them. We'll watch the providers and the front desk staff and the medical assistants go through their workflow, and we'll make suggestions and recommendations. And that's where healthcare is very different from group to group. But that's really the challenge, and I think that's the art of medicine, or the art of what we do, is getting in with these groups and making a difference. And then they can say, oh, you had a tweak here and it made such an improvement. Because at the end of the day, the goal of all this technology, the goal of everything, is not to make things smarter, but to make things simpler. It's so much harder to practice medicine now than it was 5, 10, 15 years ago. You know, the EMR came in as the great promise to make things easier, and we all would agree that it's made things harder and a little bit more complex. And so not only are we trying to treat more, we're trying to treat diseases with more complex treatment regimens, and we're also trying to deal with all these guidelines from the government about different measures.
New programs
coming in, and it's getting more and more complex. So what I'm really hoping that we can do is with AI and with technology, again, is not to be smarter, but to be simpler. If it adds clicks or it adds to the provider burden, the change fatigue is already too great. Providers and healthcare workers are already too burnt out. we have to make life simpler for our providers. And that's the goal of what I try to do with the network and what we're hoping our technology and data does. But at the end of the day, we're trying to use data and we're trying to use technology to accomplish that.
Yeah. So many of you are running in markets that have a lot of competition. I know yours does.
We do.
And you often are going to members of your network and recruiting them and also trying to retain them.
That's correct.
What are some of the ways that you've found, and I think our viewers would certainly want to know, to keep, recruit, maintain a network that is a network you want?
That makes sense. We're not trying to be the biggest network, we're trying to be the best network. But at the end of the day, no matter how nice you are, no matter what your relationship is like with these groups, no matter what story you can tell or how you represent your network, at the end of the day, it's all about value. What value do you provide for your customer, for these groups? And when you're sitting there, and typically as a provider group, we're pulled many different directions.
Sure.
And so we always have people wanting our attention, and it's why do I need to give you 5 minutes? And why should that 5 minutes then turn into 30 minutes? Why did that 30 minutes turn into hours as we develop this relationship to show the value of the network? But at the end of the day, it's all about what we can provide and what value we can provide. And I love working for Invio. I made this change because I really, really believe in the network, and for no other reason when I made the career change to be the Chief Medical Officer for Invio. And I truly believe that this network is something special. And when we can show that value and we can see not only patients' lives get better, we can look at the data and look at outcome measures, and we can truly see the patients' lives get better, but we see the providers also are happier. That together really is what it's about.
Yeah, in that sense that if the provider network is too stressed, if they aren't feeling the joy of medicine, as many would say, if they're feeling the burden of being able to take care of patients in the way they want. So there's a little bit of friction that comes with CINs and their payer partners. Where does your role sit in that process?
I would say almost as the mediator in that process.
Oh, mediator,
yeah, for
okay.
Sure. So, I have to take we take the wants and needs of the payer, and then we balance those with the wants and needs of the practices that we represent. And one of the things with the network, Invio Health Network, we have over 19 contracts. And so when I meet with provider groups, sometimes I'm meeting with them and we're going over care metrics and we're going over data for 19 groups. And our job as the network is to take this data and synthesize it so that I'm not going over 20 measures through 19 different contracts with different cut points for each one and each payer. But we're coming
So you've
with one
made
central
an
data.
elevated aggregate set of metrics.
Absolutely, we have.
Talk
yes.
a little bit more about that, because I know some people still want 27 contracts, 27 metrics, and like you said, how do you even keep track of something like that?
We still have a lot of internal discussion and dialogue about that, but my viewpoint is that you aim to provide the best care possible regardless of the plan. And so we typically like to take the highest cut points and make that our target.
Oh, okay.
We really do, because
You're not looking for averages.
I think when you average, and we do average some things, don't let me act like we don't average anything, but I really feel that sometimes when you average cut points, you can institutionalize underperformance and you can excuse some measures and some outcomes that are not as good as they could be. So I really feel like if we're aiming high, when we're meeting with the groups, now internally we might have a discussion that, hey, this is a Medicaid population, this is much harder to get on this outcome.
Right.
We know that, but that doesn't mean we aim lower. That means we still try hard, because at the end of the day, every single patient we have deserves our best.
And you want to get them to that
That's
point.
exactly right.
Yeah.
And so, again, we do some blends and things like that, but I really believe, and one of the things I'm pushing our network to do is to more and more go toward our highest target. Now, you can't get there overnight. You have to have a glide path or something, but the goal is to get to that point.
So when you think about all these metrics and the different plans that you're trying to keep track of, and thinking about whether or not you do it at an aggregate or an individual level, a lot of work is associated with data analytics and going to scale. Talk a little bit about technology, and I know our viewers are going to ask, and what about AI?
What gets measured gets managed. And so I really feel like the key is delivering good quality data that our practices and our providers can trust. It all starts there. As I mentioned earlier, we like to try to aim for the highest cut point, not for a blended middle that institutionalizes underperformance. What our job is at the Invio Health Network, and using data from Innovaccer and our great partners that we have, is to take that data and aggregate it from multiple payers into one single source. We have something called a scorecard that our providers can log into. They can get practice level data and provider level data on their patients. They can see their care gaps, and they can manage many other aspects of that. Now, we don't expect all of our providers to log in and have that impact day to day. So what we work in the background is with the systems of what can their medical assistants do, what can their practice management do, and what can our team at Invio do to support that so that providers do what they do best, which is take care of patients.
That makes a lot of sense. As you bring in new technology or consider it, do you have some criteria in mind about what it is that would make supporting that process or workflow one that you actually would want to automate or become more autonomous?
Absolutely. I judge things based on 2 questions I ask.
Oh, okay, this is
Yes,
great. You got a
yes.
2-question
2
rule.
questions. Number 1, does it make patient lives better? And number 2, does it
one.
make provider lives easier?
Okay, better and easier.
Yes. So better for patients, better for providers. If the answer is no to both of those questions, we don't consider it as just noise. If the answer is yes to one of those questions, ideally to both, then we consider that and we will pilot that and we'll talk through the specifics.
When you think about pilots that keep going on and on versus scaling that become structural, how do you get away from those pilots and into something that's scalable?
I think that what we do best as a team is we keep our family small, I would say. We have a very limited number of partners, and they're partners that we really trust. So when they pilot something with us, we're not going to 15 different vendors looking at something. We have just a few that we can pilot. So because you're right, when you have lots of different vendors and lots of different kind of people looking at things, it can become very complex very quickly.
Very quickly,
So we have a small internal team at Invio, and we have a small number of vendors we partner with to ensure that the opportunities we get are good opportunities, ones that fit the network very, very well and fit our needs.
Yeah, and I'm guessing that those that are viewing are thinking about, well, what's the difference between a vendor and a partner? How would you describe those different relationships for you?
You know, I feel like a partner is somebody that really works with you, that can help you do better, and that cares about the entire system as a whole, versus a vendor, I think, solves one problem. A partner can solve multiple problems. A partner is more of a longitudinal relationship. You know, we have a partnership with Innovaccer that lets us pilot certain things. We're able to come to Innovaccer with suggestions. You guys are not just selling us a product and leaving. It's not like, here you go, here's your project, we're done.
Good luck to you.
Good luck to you. We really, with Innovaccer and what we would call partnership, where we grow together, sometimes we win together, sometimes we lose together, we struggle together, but ultimately we succeed together.
So you're now a new partner within your own organization,
That's
right?
correct.
And you're partnering with a lot of people. When you think ahead to 2026, or maybe I should say a year from now, if we were sitting in this seat again, how would you be judging the success of what you've been able to do versus sort of where your ideas and visions are today?
I would say that we would make meaningful improvement across key metrics, both on utilization metrics and on metrics that would fall into like the HEDIS metrics. Number 1, that's the way to do it, because that's an easy way to manage that. You can look at data and manage that very, very well. But at the end of the day, kind of a softer, but I would say more important metric was how engaged are our providers with our network?
Okay.
How much do they interact with us? You know, there's tools like EndNote, for example, that we are starting to really roll out within our network. How well a year from now is EndNote adoption? How many providers are coming to us saying, hey, I heard about this EndNote, can we have that?
Yeah.
You know, that type of stuff would be the soft, would be the
So that
soft
quantitative as well as qualitative.
That's exactly right.
All on behalf, though, as you said, does it make the patient better? Does it help the provider themselves?
That's exactly right. There's so much burnout right now with providers in healthcare, and if we can help lessen that burden, again, make it simpler, that's the key. I feel like AI the next 2 or 3 years is not going to be about making better diagnoses, but I feel like it's going to be about making provider lives simpler so patients feel more connected to their providers.
So you're thinking of it much more as almost an internal operational tool at this standpoint instead of sort of inside out, maybe?
That's exactly right. That's exactly
Okay.
right. You think about automated dictation and scribing. You think about prior authorization automation. You feel like helping patients and providers interact more easily together. Things that can take burden off a provider's daily life to make them more present for their patients. Makes the patient feel more connected to the provider, leads to better healthcare outcomes. I feel like that's where we're at with AI in the next 2 to 3 years, not making it make better diagnoses for us.
Well, I'll tell you what, a year from now, we're going to need to be in these seats again.
I look forward to that.
And we're going to figure out how things went. And I have no doubt that we're going to see major improvements and just a wonderful partnership that you've made with this organization.
We've enjoyed our partnership with you, and I'm looking forward to really growing that in the next year.
That sounds great.
Thank you.
And thank you for being a viewer of this podcast today. I'm sure there were many learnings that you're going to take into your own organization.